it worked. Excellent. Excellent. Hey, Allison. Nice to see you, hon. Thanks for joining us. All right, my friends. My name is Jill Osborne. I'm the president and founder of the Interstitial Cystitis Network. I'm also a support group leader. And in fact, I am the longest serving IC support group leader in the world at 33 years. Listen, I'm really proud of that. I can't believe I lasted this long. But I'm also a researcher and I'm a writer, and I work with patients every day. This is what I do. This is what I love to do. My job is to educate you, to empower you, and most importantly, to give you hope when so many other people take your hope away. Dr. Dan Brookoff, who at one point in time was the leading pain doctor for interstitial cystitis, he became a really, really good friend of mine. He has since passed away. He said the worst thing a doctor could do is to take your hope away. And he was right. He was right. There is always hope. And if we have a patient who is not responding to therapy, then today, instead of saying, hey, well, you've got interstitial cystitis, you're just going to suffer for the rest of your life. Or as I had a doctor say to me, you will forever be a burden on your family. You will always live with severe pain. Get used to this. I went, no, I will prove you wrong, you son of a bitch. How dare you say that to me? And I have proved him wrong by far. I don't live with that level of pain anymore. I don't. Part of that journey is about, number one, not accepting somebody's blanket assumption that it felt like unworthy. Number two, you tell me no, I'm going to say yes, man. I'm going to go out and I'm going to learn, I'm going to study, and I'm going to make my own journey here, my own pathway. And that's really hard for IC patients because, you just want to feel better. You just want to get better. You're so happy to finally see a doctor and just lay it all out. I am peeing all night. I am in a lot of pain. Please, please help me. And then you get the blank look. Now, if you were an IC patient 30 years ago, 20 years ago, the odds are you'd have said, oh, that's kind of a mental and emotional problem. We need to refer you to psychiatry. And Dr. Brookoff, he was in medical school in the 80s, right? And he explained, he came out and he was a keynote speaker at one of our big IC events. Actually, it was a pain conference. And he said, let me tell you how medical school trained me in IC. We had a one-day class on urology. And so all the residents were listening to this very famous lecturer going through all the conditions that can happen in urology, whether it be cancer, prostate problems, UTI, etc., kidney stones, etc. And then literally as the instructor was at the end of the meeting and he was gathering up his notes, and everybody's, wrestling, getting ready to leave. He goes, oh, wait a second. There's one more thing we need to talk about. There's this condition called interstitial cystitis. And these patients are going to annoy you because they're going to call constantly, over and over and over. They're going to call and ask for help. They're mental. There are no bladder treatments for them. You need to refer them to psychiatry. Okay. So then another medical student in the audience said, well, what do you do for them? And the doctor just legit said, yeah, we're just going to take out their bladder. Legit. I mean, this was again back in the early 80s. And then the medical student said, well, if it's all in their head, then why would you ever even think about taking out their bladder? Good question. And of course, the doctor, the speaker, very quickly tidied up his desk and walked out of the lecture room, didn't answer it. And that really caught Dr. Brookoff's attention. And then he became a pain specialist. And he was working with a patient with very severe pain from cancer whose sister was with her supporting her. And her sister said, gosh, I really wish you would help me. And Dr. Brookout goes, well, what's going on? She goes, I've got interstitial cystitis. No one listens to me. No one will help me. Nobody will help me manage this pain. I'd rather have cancer than interstitial cystitis because at least my sister got pain care from you. I get nothing. Would you help me too? And you know what? He said, I will. And he became the leading pain doctor in the United States. But his story is and his perception of IC is very unusual in the IC world, in the urology world, because you have to understand that for decades, medical schools didn't teach doctors properly about IC, much less about pelvic pain, much less about how muscles and nerves and organs and everything interacts in the pelvis and creates this jumbled mess known as interstitial cystitis. And that has hindered our care tremendously. If you were seeing an older doctor, there is a very, very good chance that they were taught in medical school this wasn't real. And you were disregarded and or referred to psych. And you could even see a younger doctor who does exactly the same thing because that's the way he was trained by the person running his residency. And despite the fact that we have put the National Institutes of Health has put in well over $100 million studying IC, despite the fact that we have had thousands of research studies that prove that this is a legitimate condition, that this is a legitimate pelvic pain condition, we are haunted by this perception that it is mental and emotional. So what I wanted to talk, Pamela says, yep, I'm crazy. It's in my head. Exactly. And you guys, Allison, hold that question. I'm going to come back to that. You guys, I promise I will answer all of your questions. Just let me kind of get through this because I'm really thinking about this today. Let me give you kind of a worst case scenario. I had a patient back when I first started, an IC patient who was literally bleeding from her bladder profusely. And she was bleeding from her bowel, which is not part of IC. She very clearly had really significant issues that were clearly unrelated to IC, but she was bleeding badly. Her father, who is a famous doctor in her state, kicked her out of the house. Kicked her out of the house. Said, this is mental and emotional. This is your fault. And so here she ends up in I think she was in a shelter when she first called me. And again, she's bleeding. And even her own father turned his back on her. And I have no idea what happened to her. I don't. I feel I will never forget those conversations. So you have to understand that interstitial, as much as you love having a diagnosis of IC, it is carried with significant baggage. Some doctors refuse to treat IC completely. If you call and say, hey, I've just moved to this area, I'm an interstitial cystitis patient, I'm looking for a doctor to care me, some doctors, a lot of doctors say, we don't treat that condition anymore, or we don't treat that condition, leaving you royally screwed. But where do you go? So what do you do in that circumstance? Well, number one, don't say interstitial cystitis. Interstitial cystitis is too It's like a powder keg. And you fall down the rabbit hole of whatever beliefs they might be dealing with. And in the end, we know that the name interstitial cystitis is incorrect anyway, which is why most of the world uses bladder pain syndrome or hypersensitive bladder pain syndrome. So if you're seeking a second opinion and you're calling to make that appointment, say you're a pelvic pain patient. Because almost every doctor will say, oh, you're in pain, you're in pain? You got pelvic pain? Maybe that's endometriosis. Maybe that's this. Maybe that's that. They will make an appointment. But if you say, I've got interstitial cystitis, the odds are a lot of them are going to say, we're sorry, we don't work with that anymore. And even more so for those patients who have carried the label interstitial cystitis for many, many years. And the hard reality is that every suggestion that they've given you, legitimate or not, have failed. You're just not getting better. So you go to appointment, new doctor, looking for help with your interstitial cystitis. And even if you find somebody who is like, okay, yeah, let's do that, and they give you the bladder therapies or they give you the pelvic floor or whatever, but you don't get better, right? If you're not getting better, you have got to use those doctor's appointments very, very strategically. Don't get obsessed with the name interstitial cystitis. When you get into that doctor's office, you're there to say, listen, I'm struggling with pelvic pain and pelvic symptoms. And I am here because I want you to help me understand what's going on with my anatomy that's causing this. So I would appreciate it if you could help me understand if this is coming from my bladder, or is this coming from my pelvic floor, or is this coming from my skin? Because in the end, pain messages come from just a couple of different sources: muscles, nerves, skin. So what we want to figure out is, okay, are your muscles healthy? If they're not, we need to work on that. Is your skin healthy? And that's both on the outside of your body, but also inside your bladder, your urothelium. Do you have estrogen atrophy? If you do, we have to work with that. If you've got a chemical injury that's damaged your skin, we have to work with that. And is your nervous system healthy? Are your nerves healthy? Are you showing any signs of nervous system dysfunction? Do you have areas of numbness, pins and needles? That tells us if you have sciatica, that sharp, searing, burning electrical pain, we know then we've got to deal with some nervous issues going on. That's not from the bladder wall, that's from a nerve. Now, could it be a nerve in the bladder wall? Sciatica certainly isn't. It's easy to feel disregarded. It's easy to feel like there's no hope. It's easy to feel like you've tried everything and nothing has worked. I need you to become the director of your care. You're the boss. They're not the boss. You're the boss. You pay them. They don't pay you. And at this point in time, I don't care what it's called. I don't care if they call it IC. I don't care if they call it bladder pain. I don't care. I simply don't care. I just want to know what's causing it and how to treat it. Because I don't want to fall down the rabbit hole of, there's no treatment for this. I'm sorry, you're going to suffer for the rest of your life. Remember, as I had a doctor say to me, okay, don't give up. The last thing we want you to do is give up. There is always hope. And if you're not responding to therapy, we're going to take a step back and revisit that diagnosis and see what they could have missed. So as an example, I was working with a patient on Friday who, on the surface, really felt like estrogen atrophy. I mean, her symptoms started in her 60s. She was in her 70s when she called. And, in my brain, we're asking questions. It's like kind of pointing to bladder wall, estrogen atrophy a little bit more, that bladder wall phenotype. How are your muscles? Her muscles were fine, for sure. There were no issues, and no big time issues with her muscles. And then I asked that question, do you suffer from anxiety disorder? And she's like, yeah. And I'm like, okay. Do you have any other related conditions to IC? Do you have irritable bowel syndrome, vulvodynia, migraines, TMJ, anything else like that? She goes, yeah, I got all those. Got all that. So what does that mean? Well, that means she's in the widespread pain phenotype. And then I asked her, I said, okay, do you have really sensitive skin? And she laughed and she was like, yeah. Can you wear wool? No, hell no, I cannot wear wool. And then the question that makes almost everybody like go, oh my God, how did you know this? Do you have a wicked sense of smell? Can you smell things that other people can't smell, and do smells drive you crazy? And her husband was nearby and he started laughing. She's like, oh my God, yes. She's always had a terrible sense of smell. She can smell everything. Now, what that means is that she has what we call she has a central nervous maladaptation or central sensitization. She's in that widespread pain phenotype. Okay. And so the widespread pain patients are not going to benefit from bladder treatments. The widespread pain patients are going to benefit from systemic treatments. Medications just calm the central nervous system, reduce some of that anxiety, et cetera, et cetera. When you're in anxiety, your pain is amplified throughout your body. So our goal here is to calm that central nervous system down. And there's more to it. And if people ask questions, I'll go into it. But again, here's somebody who's kind of told this is an incurable disease. There's really not a lot of hope. Yada, yada, yada. And she was literally my twin. And I said that to her. I said, you're my twin. And it actually went back to an early childhood trauma for her, like it did for me, which damaged her central nervous system. So I guess the point that I'm trying to make is IC can be a scarlet letter in some medical offices. And if you find resistance to a diagnosis of interstitial cystitis, if you have doctors who are limiting your care, if they're telling you this is incurable, if they're looking at you like this is all in your head, step back from the name interstitial cystitis and just say, okay, then why am I peeing all night? Help me understand my body. What is the health of my bladder? Are there any issues specifically with my bladder? Help me understand my muscles. Are my muscles healthy or not? Help me understand my nervous system. Focus on anatomy. Don't waste time talking about a name. Focus instead, and that 15 minutes you got with your doctor, you want them studying your body. Okay, I hope that makes sense. I sent out a really big newsletter Friday, went to 36,000 patients, and it was the theme of the blog that I wrote that day. It was kind of on this topic. There is always hope, my friend. There is always hope. And you can't be passive. You have to be active. You can't sit at home and suffer in silence. You have to make an investment in time and knowledge and genuinely and sincerely working with that doctor and walking in armed for bear with questions so that you understand what you're dealing with. Because IC is not a disease for everybody. IC is a pelvic pain syndrome for which there are many potential causes. Our job is to find the underlying cause, whether it's estrogen atrophy, whether it's a tailbone injury, whether it's endometriosis, whether it's benign prostate hyperplasia, whether it's a viral infection or a fungal infection. we got to work on trying to find that underlying cause rather than just treating the symptoms for the rest of your life, because that doesn't work. Now, I got to tell you, my screen froze on Facebook. I can still see your comments, but my screen froze. It's a hysterical picture. I'll have to post it. My mouth is wide open. All right. I hope that kind of made sense. If you don't get the IC Network newsletter, it is entirely free. You can sign up for it on Facebook. You can sign up for it over on the IC Network website. I don't send out spam. I legit try to send out really direct, useful articles that will help you today manage your symptoms and understand why those symptoms are happening. All right, let's go to some questions here. Hold on a sec. Now, normally these meetings can go anywhere from 2 hours to 5 hours. I am here as long as you have questions. So you give me questions. I love questions, and I double dog dare you to try to embarrass me. I want you to try to embarrass me. I like to think that I can talk about anything without blushing. Oh, why do I have my earbuds on? That's hysterical. Okay. Oh, look at that. I can actually hear more. Hi, Gloria. Hey, girl. It's nice to see you. Hello, Serdia. She says, I've always had redness and inflammation in the bladder. What does that mean? Well, what that means is that your bladder is being tweaked by something. Your urothelium is being irritated consistently by something. Your job now is to try to figure out what that could be. Today, and I had a really great conversation with a big researcher that I did a lot of work with years ago, and he's kind of gone in a slightly different direction, but now he's kind of come back to IC. And we were talking about the origins of IC. And I just said flat out, I think a lot of IC patients are injury patients that diet soda habit, that coffee habit, that ketamine habit just constantly irritates and inflames the bladder over time. A multivitamin can do that. Anything strong, vitamin C can do that. Green tea can do that. Matcha can do that. So I would guess that there is something in your daily environment that's just tweaking your bladder. Something you think is fine that isn't fine. Hello, Dolphin. Anna says that you are a woman from Guatemala and you do not speak English. Okay. Despite the fact that I took 3 años en español, mi español es malo. I will do my best. I think it's translating for you automatically. Please feel free to ask a question in Spanish and I will try to translate it. Okay? All right, let's come back over to Facebook here. Allison said, I have an appointment at the hospital to discuss Botox, but I'm loath to do this as my incontinence is improved with physio, even though I'm having a flare at the moment, but I'd be unable to self-catheterize as the nurses find it awkward as mine is a bit off. And the thought of being in retention strikes you with great fear. Allison, reasonable fear. So let's talk about Botox for a moment. Botox, which is a deactivated tuberculin pathogen, turns nerves off. So Botox was first used, obviously, in your face to prevent you from frowning so that you don't get frown lines, which I obviously have because I've never used Botox. They sometimes use Botox in different parts of the body. They often use it for TMJ, to just try to get those muscles to release at that point, wherever they're injecting it. And they have used it in the bladder wall for many, many years, the goal of which is to temporarily turn off the nerves that control frequency urgency. Unfortunately, when they do a Botox therapy, they just inject Botox kind of randomly in different parts of the bladder, hoping that they hit the correct nerve. But sometimes it turns off your ability to urinate completely, urinary retention. And what that then means is that you will have to catheterize for a period of time, anywhere from a week or 2 to 6 months or longer, until the Botox wears off. So back when we had treatments that were stepped treatment, where you started with the easy, less risky stuff before you went to the therapies that were more dangerous, where there were more risks of adverse events. We had 6 steps. It was in step 5. It was the last step before surgery, specifically because of the urinary retention. They have since found that if they reduce the dose, the risk of retention diminishes. But Allison, it is a legit concern, and Botox is not supposed to be used in patients who are unable to self-catheterize. So if you are unable to self-catheterize, you are not a candidate, period, end of story. You're just not. Pamela said, IC bladder, vulvodynia, 26 years, my doctor this week. I hurt vulvodynia. He said, I have a skin disease. He put you on Aveeno, normal, dry, sensitive skin, no fragrance, started this week. Years of believing that it was all in my head. Okay, so Pamela, if you've had vulvodynia and IC for 26 years, you are a central sensitization patient like I am. And so the good news is now we know that, and now we know that therapeutically we have to focus on calming and soothing nerves. Here, hold on a sec. That's the IC Network phone. Let's see, hold on a sec. Let me just tell them I'm doing a support group meeting. Okay, let's see here. Reset. Okay. Okay, so again, I had vulvodynia in high school. I had it for years. So what do we do with vulvodynia? The assumption is that the nerves in the skin of the vulva are very, very inflamed. And now if you're older, the odds are you probably also have some estrogen atrophy going on. Our goal here is to protect those nerves. This means, number one, we don't use chemicals that are stimulants. So we're not going to use bubble bath. We're not going to use bath salts. We're not going to use Irish Spring soap or any soap that has a very strong scent. We're not going to use typical laundry detergents or especially fabric softeners. It's about calming the nerves. So using a soap for very, very sensitive skin, like Dove for very, very sensitive skin, which is what I use. Using 7th generation free and clear laundry detergent, always rinsing your underwear twice. Absolutely no sense at all. Can't use anything that's perfumed down below. You may have to look at spermicides. If you're using spermicides, you could be reacting to that. You may, if you've got atrophy, you may need to treat that atrophy with some estrogen cream and some vulva balm. Okay. But calming nerves down. And what I would be looking at if for a supplement would be a PEA supplement, palmitoyl ethanolamide, also known as Peora or Peely, because that acts to calm nerves down. And we've got research showing it helps IC and helping vulvodynia. Mary said she's having some audio. The audio is out of sync of the video. Yeah, Everything's unpredictable. All right, let me come back to YouTube. And let me, so I've got Anna's question in Spanish. So let me see if I can translate this. She says, I've had IC for 6 years and I haven't found any medication or doctors to help me. What can I take? Okay. Anna, it begins with trying to understand what's causing those symptoms in the first place. You've had this for 6 years. And what you've done up to this point has been ineffective. So today we consider IC a pelvic pain syndrome with many potential causes. So we know that some patients have big wounds on their bladder called Hunner's lesions that have their own treatments. We know that a lot of women have estrogen atrophy affecting their bladder. It's not a disease, that's just skin a thinning and drying as we lose estrogen. We know some patients have an injury to their bladder because of a chemical exposure, whether it be chemotherapy or drinking way too much Diet Coke. We know a lot of patients have muscle problems. That if your symptoms began after having a very difficult childbirth, or if you were in a sport where you fell a lot, like gymnastics or ice skating, or you were a dancer, ballet. Believe it or not, ballet is associated with pelvic floor dysfunction. So we want to know, are your muscles healthy? And then last but not least, we want to know, do you have any other conditions which help us suggest a nerve problem? So until we have that answer, it's hard to suggest anything. There's no one treatment for everybody. Today, I mean, we know that when we treated IC that way, it didn't work for most patients. Instead, we want to have a more specific diagnosis. So I would be happy to talk with you if we can find someone to translate. And I can guide you through that. So if you have a family member that speaks English, that would be great, that you wouldn't mind talking about your bladder in front of. Dolphin says, I'm having a pelvic and kidney ultrasound in a few days. They want me to drink, 32 ounces of water 1 hour before. I am so worried I will not be able to hold it. I am a pelvic organ mesh survivor. Right. And her bladder was damaged when they removed mesh. Okay, hon. I had exactly that same fear. I can tell you exactly when it happened. My last year of college, I had a bunch of ovarian cysts. One of them ruptured badly. I had to fly home. I missed my finals, believe it or not. And because I had to go have a surgical consult for these ovarian cysts. I mean, I had like 10 or 12 ovarian cysts. And they wanted me to drink 2 big glasses of water, and I knew I couldn't. So I did a fake out. Now, okay, well, so what happened is I drank the 2 glasses of water, and then I got to the hospital for the ultrasound, and they were running late. And the receptionist in radiology said, well, can't you just pee a little bit out? And I'm like, how do you do that? When I need to go, I need to go. And so, I had to pee because they were an hour late, and then I just drank another bottle of water and it was fine, and they didn't even know. Here's the way I approach that now. I know for a fact that I'm not going to be able to hold a large amount for a long period of time without feeling very, very uncomfortable. So what I do is I drink a glass of water before, just as I'm leaving for the appointment. The appointment's 20 minutes away. I'm going to wait 10, 15 minutes, usually there. So 30 minutes later, I've got a reasonable volume of urine in my bladder. I have done that. How many times have I done that? I have probably done that 4 times now in the last 30 years. Nobody's ever caught me. I mean, nobody's ever said there wasn't enough fluid in my bladder to do the test. You know, so it's not my position to tell you to ignore instructions. You really never want to do that. I'm not telling you to ignore their discussions. I am telling you that if they ask you to drink a large amount of fluid and you get there and your bladder's full and they expect you to wait, that's completely unrealistic. You're going to have to go. It's going to hurt like heck. And my work through instead, which absolutely worked, was instead of drinking that big giant glass of water an hour before the appointment, I drank it literally as I was getting into the car. Get there at the other end, they have no clue. None at all. So I'll just offer that. All right, let me come back to Facebook here. And you know what? I just drank this, a big giant smoothie, and I'm going to have to go to the bathroom very quickly. That was my breakfast and lunch. Allison said, I've had IC and lichen sclerosis in the United Kingdom since 2009. I've been pushed from pillar to post and not taken seriously in the beginning for a few years and told it was all in my head. You even lost friendships. Because you can't socialize like everybody else. Yeah, girl, I totally get it. I've asked before, but I'd love to try your supplements, but I can't get them in the United Kingdom. So just fumble around trying to find cures or things to ease. So Allison, again, you have to make your decision based upon your phenotype. Okay, so you can't just grab this and that and this and that and expect to get success. You can't come on the internet and go into IC forums and just try everything everybody else says. You're just going to waste money. We have to understand your body. So if you want to Zoom, let's Zoom. We can Zoom sometime this week. And let me just ask you a bunch of questions. I mean, no charge, honey, no charge. And let me see if I can point you in a better direction based upon your phenotype. Pamela said, yes, in my feet and hands, shocking and numbness burning on the pelvic floor. So I literally have some clients who, when they flare, their feet go numb. Both feet go completely numb. Bladder flare, feet go numb. That's a pelvic floor flare. That means their muscles are so tight, they're squeezing the nerve shut. Okay, I need to go get rid of my smoothie. Give me 30 seconds. I'll be right back. I should have had it 2 hours ago instead of an hour ago. Give me a quick moment. Okay. Thank you. Now here's an interesting question. When you pee, does your urine go flying off in random directions? Like to the left or to the right? Or even out in front of the toilet? Or on the wall next to the toilet? That's a sign that you probably have tight muscles or stricture. So when I just peed, that didn't happen, but it has happened to me before. I am a pelvic floor central sensitization patient, and I always wondered. I had many moments where my pee would go to one side or kind of spray scattering in weird directions. Now I know that was all driven by muscles. And my muscles got really tight this week. So I did my internal physical therapy, and man, they were tender to touch. I need to do it again too. Oh. Okay, hold on. What's going on there? Okay. Pamela says, what kind of doctor for the nervous system? Well, sometimes it's a neurologist, especially if you've got numbness in your feet and hands. You go to a neurologist. You were told no cure forever. Not necessarily true. We got to know what we're dealing with here, hun. And I think that's a big part of the problem is you don't really know what you're dealing with. Cynthia said, I had a urologist diagnose me, and was it an ER doctor that helped you? Yeah, good. Whenever I work with ER doctors, I am always talking to them. And whenever I'm in the ER, I've been in the ER several times in the last couple of years because of post-operative infections and COVID and pneumonia and stuff. I always talk to them. Tammy said she tried aloe vera plus gabapentin, and it does help. And when I get my hormones more in line, that helped too. Good. So aloe vera is soothing to tissue. It's like putting aloe on a sunburn, feels good. But just understand that there's no published research that shows that aloe vera is beneficial for interstitial cystitis that's ever been published in a journal. And just to check again, I'm just going to do a quick search because you never know. An article might have come out. I'm going to the National Library of Medicine. I'm putting in aloe vera, interstitial cystitis. Let's see if anything comes up. Nothing. Nada. Aloe vera is an old school approach that is really, now that we're phenotyping, has a very small use window. So is it going to help Hunner's lesions heal? No, but lactoferrin would. Is it going to help estrogen atrophy? Is it going to help the bladder make mucus? No. Estrogen does that. Is it going to help pelvic floor dysfunction? No. Is it going to help central sensitization? No. But if you're having a bladder wall flare and your bladder's screaming in pain, doing a couple of days aloe makes total sense just to kind of calm and soothe that tissue. Cynthia says the diet has helped me so much. So what that means then is that you're very bladder wall driven. And I can't see how old you are, but generally the very first thing we look for is estrogen atrophy or the genitourinary syndrome of menopause. Jana says, can a swimming pool water cause a flare? Absolutely. Absolutely. I remember I've worked with many patients who have had issues with swimming pools. Jana says Botox has changed her life. Excellent. I'm glad that it helped. I'm really glad that it helped. Clearly you had a very experienced doctor. That's wonderful. Jana says, is there any news on blood palette therapy? Blood palette therapy? I've never heard of blood palette. Hold on, let me look. Oh, platelet therapy, not palette, platelet therapy. Platelet rich plasma. That's probably what you're referring to. And the answer is yes. And let me just pull up the study. Not a lot of research, but there's some. I just don't remember it off the top of my head. So let me. Platelet-rich plasma in selected urologic conditions. The effect of combining low-intensity shockwave therapy with platelet-rich plasma among female patients with IC, and that is from China. Here's one: reconsidering the evidence for platelet-rich plasma and interstitial cystitis. And of course, that is from the Middle East, and they don't have the text available. Repeated intravesical platelet-rich plasma alleviates symptoms via T-cell modulation and mitochondrial dysfunction in non-ulcerative IC. Okay, let's just look at this one here. Intravesical PRP injection may represent a promising therapeutic option for refractory IC. So what does refractory IC mean? It means it's not responding to any other treatment. Showing trends towards improvement in pain, nighttime urination frequency, and bladder capacity. However, current evidence is derived exclusively from uncontrolled and non-randomized studies. Therefore, its efficacy is uncertain, and the findings should be interpreted with caution. Nonetheless, higher quality randomized controlled trials are required to confirm that it actually works. So we've got a lot of early research, but nothing that's really conclusive. Hello, Bonnie, my friend. How are you? Pamela is asking about the PEA. It's like a green pea, PEAORA, Peora. You can find that in the IC Network shop right now. It's what I take. Donna said, I'm considering taking magnesium for a slight neuropathy of my toes. Does magnesium affect IC? Not usually. Magnesium is known for affecting the bowels more. And so, sometimes a little goes a long way. I take magnesium every night for muscle cramps and also just to kind of keep my bowels fairly happy, and works great. It certainly never flared my IC. If anybody else out there has flared from magnesium, please let us know. Mary said, is essential tremor related to IC? Well, essential tremor is driven from the central nervous system, right? And so is essential tremor related to widespread pain? I don't believe that there have been any studies which have supported that. I inherited essential tremor. I have it myself. You can see it when I do these meetings. What happens is when my neck gets really tight, my head starts to go like this. That's my tremor. Or if I use my fingers really hard, like out in the garden, if I'm pruning a lot, I will get a quiver in my fingers for about an hour. Arlene says, when you take Bladder Builder, do you need to buy PEA so you can take more than is in Bladder Builder? Not necessarily. Bladder Builder has a good chunk of PEA in it, although many patients will do one extra PEA with the Bladder Builder. I see a question that was hidden about a colonoscopy prep. I'm just going to say that It's very rare that patients flare with colonoscopy preps, but they are scary because some of them are lemon or orange flavored, and they often have citric acid in it, which is scary and intimidating. I will tell you that when you're doing a prep, you're not going to be paying any attention to your bladder. You're going to be sitting on the toilet pooping for hours. So it's actually, remember, pain processing is such that the most important pain messages get sent to the brain for action. The most important messages that are going to be happening when you're doing a prep is related entirely to your bowel. So the odds of you actually feeling a significant bladder flare, I would consider pretty slim. But you can certainly work on your prep if you're worried about it. The Miralax protocol is the protocol that I used. It's very gentle. Basically, you take 5 biscotals, and then you have 2 jugs of water, and you put Miralax in both, and you just drink it down and then spend the next couple of hours in the bathroom. And listen, I'm just going to warn you right now, if you're doing a colonoscopy prep, you need to tell everybody in your family, no one can use that bathroom. That is your bathroom until you are done. They may not go into it. They may not close the door, because you, my friend, are going to be running suddenly to the bathroom, and you cannot be met by a closed door. So hopefully you've got 2 bathrooms in your house, and you're just going to put a sign on one, and you're literally going to be hanging out 5 feet from the bathroom. Like, get a recliner, bring your iPhone, bring your iPad, watch movies. If you're laying on your bed, lay on your bed, but you're going to need a clear, clean bathroom, a clean pathway to that bathroom during that colonoscopy prep. And yet it's just so important that you do it. I had mine done over 10 years ago, and I need to have another one. I do that stool test where they look for blood, and I've never had blood in my urine. So, but I know it's coming again. Anne said lots of peeing at night. Why? I was told estrogen would help. It's not. And nocturia is being driven by the alpha afferent nerve in your bladder wall. So that's the nerve that tells you when you need to urinate. And so something is tweaking that nerve. And so we've got to figure out what is specifically tweaking that nerve. Estrogen atrophy basically exposes the nerve, because your bladder doesn't have enough estrogen to make the coating which normally protects the nerve. And so that estrogen is really, really important for helping your bladder protect tissue. So don't stop the estrogen. Estrogen, a lot of patients go, well, I started estrogen, but it's not helping my symptoms. Well, it's not meant to immediately help your symptoms. It's not a bladder therapy. It's about making your skin strong and healthy. And that's a lifetime journey for a menopausal woman. Mary says, what does lactoferrin do? Lactoferrin is a protein found in colostrum that is a front line of defense for our immune system. Our body makes our own lactoferrin. We have lactoferrin right now that our body made in our tears and our vaginal fluids. It is a front line of defense for our immune system. It helps our immune system fight off infections. Unfortunately, as we get older, sometimes our body struggles to make enough lactoferrin, and that is where using lactoferrin from cows has been studied extensively for a number of medical conditions, and it's generally been quite helpful. So in 2024, a lactoferrin IC study was done of 31 patients. At the end of that study, 28 out of 31 had no bladder symptoms. Their red inflamed bladders had become pink and healthy, and their Hunner's lesions had virtually disappeared. This is the first time we've had a treatment ever do that. They also measured systemic inflammation with blood testing, and systemic inflammation was down too. So lactoferrin is one of what I call the next generation supplements. That is absolutely a supplement that we're going to be focusing on in the future, especially for patients with Hunner's lesions, but really for anybody with significant inflammation. There is a blog on the front page of the IC Network, which gives all the research. You can read the research yourself. I'm excited. Cynthia is 65 and has atrophy. Girl, I am 66 and I have atrophy too. And I've been dealing with a lot of dry mouth this week. Very weird. Hello, Sue. It's nice to see you. She says, I hope you're doing well. You listen while you're working on silk flowers for your daughter's wedding. Aww. Which magnesium are you taking? I'm doing magnesium glycinate for spasms, but I also do get constipation. I just heard doing a magnesium with different types can some be better. I don't know what kind you're taking. I do generally magnesium glycinate just like you, although the last time they didn't have any in the store and I got a different one. And it's doing really well too. So go figure. Mary says, my pharmacist told me that Miralax absorbs your medication in your system. Well, we were just looking this up. What were we looking this up with? There are some medications that's absorption will be limited when you do certain things. Like, for example, if you're using calcium or if you're using magnesium, there are some medications that very specifically you have to wait an hour before you do any food after you take that, specifically so that the medication can absorb into your bloodstream without being deactivated by something that you've eaten. So, but I'm not sure about a Miralax absorbing medication in your system. I don't know. I mean, you're only using it literally for a couple of hours. I mean, you're using one tub and that's it. So can you afford to lose a little bit of medication in that period of time? Maybe. It depends on what medication you're specifically referring to. Like, I take a blood thinner for AFib. So I now ask, can that medication interfere with a blood thinner? Or can that medication interfere with my heart medicine? You know, I certainly want to know that. Man, getting older is not for the faint of heart. All sorts of weird things happen when you get older. I am living proof of that. Morales. Oh, look at this. We've got two people that have connected with each other who are speaking Spanish. Yay! Dolphin said, my neurologist diagnosed me with neuropathy in my feet. I was diagnosed after my pelvic surgeries. I also have tailbone and pelvic pain, pudendal nerve damage. I didn't know my neuropathy could be caused by my pelvic muscles. Well, you know, neuropathy is certainly the result of some sort of injury, right? And so something injured the nerves down there. And it would be nice. I mean, it could be other medical condition like MS, but for a lot of patients, it's just like, for me, I was an athlete and I really badly damaged my feet as an athlete. If you were a runner, you know, all sorts of funky things happen. All right, hold on. Is it going to work? Kind of messy back there, but it is what it is. Veronica says she's got MS. Yeah, my college boyfriend and love, his name was Guy, and I adored him. We were in pharmacology together, and he had MS. Yeah. So I learned a lot about it really, really quickly. And his was very, very aggressive. It was, we thought he, it was just very, very aggressive back then. Oh, don't even get me started on that. Dolphin said, I received your awesome newsletter. Can you tell us about pulsed electromagnetic therapy? So, also known as soft pulse. So, it was one of Dr. Ken Peters' patients who called me last year and said she had started a new treatment with Dr. Ken Peters that had her substantially better. Now, Ken Peters is, in my opinion, the best IC researcher in the United States. I have known him. I met him literally at my very first IC conference back east. What I really liked about Ken Peters, number one, he is a master diagnostician. Like, I send him so many complex cases that no other doctors can figure out. And he's so good at looking at anatomy and really trying to understand what's driving symptoms. And he's also not biased in favor of any treatment. I mean, he lets the patient drive the treatment, not the treatment driving the patient, if that makes sense. So, anyway, so she said, yeah, he's using this new treatment. It really helps. So I immediately emailed him and I said, so what is this new treatment you're doing? And he raved about it. He said it's helping lots of people. And so it's a very gentle shockwave therapy that is done. You can lay on a mat, or it's a mat that goes over your belly. And he said all of his patients appear to be benefiting from it. It's very good at reducing inflammation. It's not invasive. So that's very, very new. I'm cleaning my glasses here. They got funky. Oh, so I can see. All right. So pulsed electromagnetic therapy is viable. And I think we want to learn a lot more about it, because when you have somebody of Dr. Peters' stature just saying with a glowing testimonial, it's really helping a lot of patients, we want to look at that a lot more closely. Let's see. So our magazine is done. Our IC Optimist magazine, your e-version for our members, you can download right now on your member page over in the IC Network shop. The print version, we should have it from the printer tomorrow, or Thursday Tuesday at the latest, and then we'll throw all those in the mail for the people who get it by mail. We've covered two interesting guidelines that were just released for IC from Europe. One was the International Society for the Study of IC. It was focusing specifically on diagnostics. How is IC supposed to be diagnosed? And then the other one was from France. It was the French Association of Urology's new guidelines for IC. Everybody agrees that there are phenotypes, but now they're kind of debating and disagreeing about what are the phenotypes. And it's like, listen, the fact that you're recognizing that we can be very different is critical. They'll be debating specific phenotypes for a decade, most likely. But for the first time, we're really seeing an emphasis on identifying patients with autoimmune disorders like rheumatoid arthritis, Sjogren's syndrome. There are conditions which can affect how the bladder behaves. And they did not provide treatment recommendations. They just said, if you have a patient who's got rheumatoid arthritis and Sjogren's syndrome or lupus, and then they develop bladder symptoms like IC, then it might be caused by the autoimmune condition. And then the other thing was really talking about neurogenic bladder. And neurogenic bladder is where the nerves supporting the bladder or functioning in the bladder have changed for one reason or another. And that's where, Veronica, the MS would fit. And again, treatment is going to, number one, focus on the MS. And in fact, I swear, just this morning, there was a new announcement about an MS therapy. Where did I see that? You know, I pay attention because a man that I love dearly had MS. And so let me see if I can find that. Where did I see that? Here's an email from somebody who got my newsletter who said, would you please do something on PGAD? And yes, I will, for sure. Okay, so hold on a sec. I swear I just read something on that, like in the last 24 to 48 hours. It's not where I thought it was. Yeah, no. I totally read something that was talking very, very specifically about, was it on CNN? Where was it? Hold on. What did I look at today? I looked at CNN. And I looked at my email. That's all I did. Yeah, it was like, I know I did. 100% no. What's it? An MS? I swear. It was like yesterday. With something that targets brain inflammation, emerging remyelination therapies designed to repair nerve damage, and early trials using CAR T-cell therapy to reset the immune system. Yeah, here it is. Here it is right here. It's called PTD-802. The FDA cleared the first human clinical trials for new oral remyelination candidate designed to actively rebuild the protective myelin coating around nerve fibers. Hey, man, my memory is still here. Despite the fact that I often walk into rooms and forget why I'm walking into the room. Yeah. Look at that. I found it. So I am going to, Veronica, post a link to that. You might find that interesting and comforting. There you go. All right. Hello, Noreen. It's nice to see you. Donna said I had to leave. Might have missed your answer. Which magnesium is safest for IC? I don't think we have a legit answer or study that's ever defined what's safest for IC. I think this is one of those situations where you just have to try it and find one that works for your unique body. I mean, I've been fine with magnesium glycinate myself. So Sue said, my PG symptoms went away when I started doing pelvic floor Botox injections. They were sometimes mild to medium symptoms, but never severe. And now you rarely have them. And you are pelvic floor and nerve driven. That's great. Thank you, Sue, for sharing that. That's wonderful. I wouldn't mind doing a Botox injection in my left butt cheek around the muscle that quivers all the time. I'm just stuck in Kaiser Permanente. And Kaiser Permanente, believe it or not, they don't offer trigger point therapy or anything like that. You have to go out and find somebody. Oh, and I just haven't had the time to do that. You're welcome, Veronica. Said she had heard about that. Yeah, that's exciting. I have a cousin who has MS, so I really, and she inherited that from her dad's side, and all of her siblings have MS. Donna said, any ideas for safe salad dressing? The best salad dressing you could possibly do is an infused olive oil, which were very popular 10 to 15 years ago, like a basil infused olive oil, a garlic infused olive oil, if you like garlic. Otherwise, homemade is always better than pre-made. Especially salad dressings that come in packets that have a lot of preservatives in them and salt and MSG and things like that. So making a homemade ranch, making a homemade blue cheese might be okay. Italian salad dressing can be a little bit tricky because of the vinegar, which is why it's just use the infused. And I will tell you, for me, I eat salad every day, but I don't use any dressing at all. I put on it is artichoke hearts. And the artichoke hearts have that little bit of flavoring there, and that's what I use. So just homemade, or if you have Mary's salad dressings, which are refrigerated in the grocery section of your grocery store, they're in the vegetable aisle of your grocery store. Look at the ingredients there. Those have been a go-to also for many patients. Noreen says, what is a safe leaf lettuce or a romaine? Well, lettuce is not linked to irritating the bladder. So you can pretty much do any lettuce you want. The challenge with lettuce is if you have irritable bowel syndrome or gastroparesis, and this is going to sound weird, but you think lettuce is soft, but it's actually fairly rough on the gut. It has sharper edges. And Heather Van Voris, the lady who wrote Help for IBS, or she wrote First Year IBS and has this fabulous website, Help for IBS, talks very specifically about how lettuce can trigger an IBS attack. It used to do that all the time for me. Back in the day, before the internet, when we had shopping malls, the girls would get together and go have lunch at Macy's and get a salad and then go shopping. And of course, all those closed, and we don't do that so much anymore. But I can't begin to tell you the number of times I ended up with diarrhea after eating salads. And it was the lettuce irritating the sensitive nerves in my bowel. So the salads that I eat now do not have lettuce in them. They have carrots, they've got peas, they've got corn, they've got garbanzo beans, they've got radishes sometimes, they've got olives sometimes, and artichoke hearts, and works like a charm. But if I eat a leafy green, I tend to have problems with leafy greens. Even pre-cooked leafy greens, like a frozen spinach omelet, I really can't do. They just bother me, which is a combination of the oxalates combined with the fact that I have very sensitive nerves in my stomach and in my bowel and sharp edges and oil. Same like with granola. A lot of people say if you're constipated, you need to eat a lot of cereal, eat a lot of granola. So believe me, I can eat a lot of granola. And I can have large poops, but they're uncomfortable. They're painful because of all the sharp edges of the granola. This is why IBS patients don't do insoluble fiber like granola. We do soluble fiber, which is fiber that dissolves in water, which is gentler. So, yeah, I sure learned a lot from Heather. She has taught me greatly, and she has great products. Here, hold on a sec. Okay. I thought, here, hold on. I just thought yeah, I did. Let's see. All right. So, Noreen says great information. Good. Glad to help, hun. Glad to help. Okay. So, what's happening in the IC world? Well, my friends, IC awareness starts on September 1st, IC Awareness Month. And let me give you the lowdown on IC awareness, because believe it or not, I played a really big role in it for many, many years. So, years ago, 25 years ago, like 1996, 7, 8, IC awareness was originally a day in November, one day, that a patient group in California created. And then that group folded. There's been a lot of folding and a lot of activity in the IC patient population and in nonprofits and support groups. So that original group, which is based in California, created IC Awareness Day in November. I think it was the day before Thanksgiving. Then when that group folded, the people who made Elmeron took it over, and they had an IC Awareness Week in November. I think it was November. And it was very disappointing because it was just, so people would sign up. There was a support group program called Turning Point. You signed up for this support group program online, and then you got emails promoting Elmeron. And it was just a waste. And I remember I did one event with them online, and then they got into a fight with somebody else, and they walked away from IC awareness. And so for a year, nobody did IC awareness. And I was kind of waiting to see if the ICA was going to do it. Nobody did it. And I thought, okay, I'll take over IC Awareness Month. So the first thing we did is we had a big vote online with thousands of patients. The problem with doing anything the pharmaceutical company moved it to October. The problem with October is breast cancer awareness. You can't get any media exposure in October. It's all dominated by breast cancer. So we put out a big vote online, thousands of patients voted, and we moved it to September. And then instead of doing a week, we decided to do a month, because it would give us 30 days of doing IC activity. And we did, and that's the way it's been now for 15 years now. And I run that website and write all the press releases and stuff like that. We did proclamations. We did poster contests. We had great posters that patients submitted that we still use today. We did memes. And the goal of IC Awareness Month is not to promote a group, ICA or IC Network or anybody else. The goal of IC Awareness is to give you something you can use in your community, whether it's a poster, whether it's a press release that you can send to your local paper, because in the end, it's about improving care for you. And I don't know what's happening in your community. You know what's happening in your community. So if you have a school that is denying restroom access to a kid in high school who's got IC, if you've got doctors who are refusing to treat IC, if you have an employer who's not letting you use the restroom, okay, these are all issues that we have covered and will continue to cover in IC Awareness Month. So the goal of IC Awareness Month is to give you resources that you can use to make change in your community. So you can put posters up if you want. We got beautiful posters. You just download and print them out on your computer. You're good to go. We've got a press release pre-written. Although I haven't written the one yet for this year, but I will in the next 2 weeks. We'll do it. You can print out that press release and you can send it to your local paper. And better yet, you can tell your story. Because here's the deal. The newspaper doesn't want to talk about the ICA or the IC network or any nonprofit. They just don't want to do that. They want to know how a life was changed. They want to hear a patient whose life either got better or got worse. It's all about patient stories. And so what I really encourage you to do is with our newsletter, with our press release, you can share your story and say, this is really important to me because I live in this town and this is how I was treated. And this is wrong. And I would like you to do a story on this condition that many doctors refuse to acknowledge, or, whatever angle you want to take on promoting IC in your area. We also have, here, hold on a sec. We have got restroom access cards. And we have got food cards, foods to avoid, usually bladder friendly. And so what some patients do is you buy 10 or 20 of them. It's like under $10 for like 20 of them, I think, if I remember correctly, $9.99 is to buy a bunch of these. And then if you go to the movies, leave like 5, by the mirror. Let other people grab them. And the cool thing is on the back, it explains what interstitial cystitis is. It gives a link to the websites. So IC awareness isn't about me. It's about you. And now what we do have are daily facts that we try to put out every day. So we've got, I've already done all of them on TikTok. We've got graphics that you can share on your website. On your social media. We've got sound bites that you can share. There's so much that you can do. And I really need you. If not you, who? Whose responsibility is it to actually raise awareness about IC? You cannot put that on my shoulders. It's not fair to me. I am one voice in the crowd. We have to have lots of people speaking out. We have to have lots of people. Another thing that I say to patients, you got to understand right now that we have no IC research program at the National Institutes of Health right now. Since the 1980s, we've always been funded. Not now, not under this administration, and it infuriates me. It infuriates me what's happening. Grant writers have been told not to use the word women in submitting research studies to the National Institutes of Health right now. That tells you the priorities that are happening and the diminishment of women's health. And it is an undeniable fact that that is indeed happening. Okay? If you want that to change, you got to write your senator and say, hey, why aren't you funding IC research? Why don't we have more research supporting this condition that affects millions of people? It affects millions of people. The MAP Research Network is done. It's over. And, I emailed Quentin Clemens, who ran that for many, many years. It's like, what do we do now? We don't have an IC research group at the NIH anymore. What do we do? What are the odds? What's the outlook? Does it look good? He said, no, he didn't think it looked good. And it's like his suggestion was to combine our work with a pelvic pain group, which I agree with. And so then we started putting out feelers to pelvic pain groups to see if we could create some sort of team that would study this more in depth and, more importantly, encourage research funding, because it is a dire situation right now. So if you're in pain, if you're up in the middle of the night crying your eyes out because you're hurting so badly, put that pain to work. Turn on your computer, write a letter, or better yet, write it out by hand and describe what your life is like with IC. Describe how you're suffering right now as you're writing this letter, and how you need their help. You need them to support research funding for interstitial cystitis and pelvic pain. And you send it. Speak out. Share your pain. Use that pain constructively. That's the only way we're going to get back to previous funding. Because right now we do not have any pathway that will launch us back into a big federal IC research program. And the other really heartbreaking thing is that, I work with the international groups regularly. We were once the shining star of research. We are not anymore. We're now at the bottom of the barrel when it comes to IC research in the world. You know who's shining in IC research right now is China. And all the international groups have been getting together for the last year to really work on this, because we see this around the world. We absolutely see this happening, that research has been diminishing. It's getting harder and harder for IC patients to find care. It's getting harder and harder to get companies interested in IC to help to create new therapies. And it's getting harder and harder to support the research community. My big fantasy, if I ever won the lotto, is I'd create a research foundation, for sure. I have fantasies, and they get me through. That is a big fantasy for me. I just would love to bring in, with no politics, with no favoritism, let's just bring in a group of the biggest researchers and say, okay, what do you need? What do you need? What can we work on now? And I would be working on the UTI vaccine. I would be working on fungal infections. I would be working on drug-resistant infections. I would be working on Hunner's lesions, making sure that we have invested a lot of time and money in trying to understand why Hunner's lesions are happening, and more importantly, how to treat them. I would be doing a lot of research on the central nervous system, or what can we do to calm the central nervous system down for patients in pain. I would be doing a lot of research on pain care, because the hard reality is that patients suffer. It doesn't matter if it's IC or not. The suffering right now is unreal, because we don't have access to the pain care that we used to have. And that, again, that also infuriates me. So that's something else you can put in your letter when you're writing your letter in the middle of the night, crying your eyes out. Why am I refused pain care? I am in agony right now. Advil doesn't touch it. Tylenol doesn't touch it. Why do these guidelines prevent treatment for my legit pain condition? I have got lesions on my bladder. They are open wounds on my bladder. Why am I denied pain care? Would you please help me understand what's happening? Because don't even get me started on the pain guidelines. Dear God, was that a catastrophe? And when they created that first set of pain guidelines, there wasn't a chronic pain specialist on the panel. It was really run by people who run drug rehab programs who directly benefited from taking patients off of pain meds. They'd have to go into rehab. Oh, don't even get me started on that. Listen, I can rant. I can rant just like anybody else. I can definitely rant. Susan said, yeah, suffering and doctors don't want to give you anything for the pain. I now am, because I chaired the state of California pain conference, okay, years ago. And I worked with the Bureau of Narcotics Enforcement and worked with the top pain doctors in California for sure. And we got the governor to sign our pain patients' Bill of Rights. And that was something that I was really incredibly proud of. And I am very, very direct with my doctors. And if I have to have surgery, because I've had 2 major surgeries now in 2 years, double mastectomy and gallbladder removal. Gallbladder removal first, and 3 months later, they found breast cancer, and I had that. And I will tell you, at every pre-op appointment, I was this blunt. I said, I will not do this without opiates. I need a prescription in my hand right now. I refuse to do this on Advil. My mother did a hip replacement on Advil, and oh my God, did she suffer. She suffered because she was very allergic to opiate meds. And I mean, man, the hammer comes down. It's less like, I'm sorry. I'm not letting you cut into my body unless I have a guarantee from you that I will have pain care for at least a week. And both surgeons, actually it was the same surgeon. She's like, well, I wouldn't do the surgery without making sure you had pain meds that first week. The challenge is that, and I said this to my OBGYN, I said, listen, I don't trust the outpatient surgery center to make sure that I have opiate pain meds. I've heard too many times of patients who were told they'd have pain care, they have the surgery, and as they're being wheeled out in a wheelchair, you find out, yeah, their pain care is Advil. It's like, no. So I'm very clear with the surgeon. I need a prescription. I need to see the prescription. I am going to fill the prescription a day or two before the surgery, so that prescription is on my bedside table when I come home from surgery. And I'm just very, very firm about that. It is what it is. Kayleen said, you have a medical marijuana for icy pain, but it's only a 6-hour Band-Aid. I'd rather be in pain than get on opiates. Give me 2 days of perks after surgery and I'm done. Yeah, I'm not, you could not have gotten me through a double mastectomy on 2 days of Percocets. No, wouldn't have happened. So the way it worked for me is really only the first 2 days did I need a whole pill. And then I went down to a half a pill. And then I went down to a quarter of a pill. And so by the end of 7 days, I was taking a quarter of a Norco every 4 hours and keeping the pain under control. But if you accidentally move the wrong direction, then, it's important to have some pain care. Right. I need to pee again. You guys, sorry. I had a big giant smoothie right before I started the meeting. So my bad. I'll be right back. Oh, the relief. Kayleen said only helped for 3 hours for me. Yeah, Norco is a short-acting opiate. I mean, you basically, you take it, you got a half an hour before it kicks in. It's going to work for about 3 hours, and then it's a half an hour as it calms down, which is why they suggest that you take it every 4 hours, every 6 hours. You just gotta, you have to learn your body tolerances a little bit more. I think that, okay, so I had no pain care my first year with IC, and I will tell you the pain was insane. I was up most nights laying in the fetal position in my living room. I mean, I'm not lying. The pain was bad. I was running to the bathroom every 15 or 20 minutes. I wouldn't flush the toilet because I didn't want anybody to hear me. And I was just an absolute wreck. No pain care at all, which is ironic given the fact that I'm a pharmacologist, right? It's like, didn't even dawn on me to ask for pain care for bladder stuff. And then I made a horrific decision. I just thought I just needed to get away. And so my mom and I took a train up to Lake Tahoe, a 4-hour bumpy train ride. And when you're in a wicked pelvic floor flare, the last thing you want to do is be on a bumpy train. And when we got up to Tahoe, I was a wreck, and I ended up in the emergency room at like 4 a.m, just bawling my eyes out. The pain was so bad. And they gave me a shot, and it turned all my bladder symptoms off. And I was just stunned. It's like, wait, you can turn this off? I mean, I was genuinely stunned. It just hadn't dawned on me to use pain care. I was just focusing more on bladder therapy than a pain medicine. And my sweet elderly mother, who had stopped driving freeways a couple of years before, had to drive me home in the rental car from Lake Tahoe back to Sonoma County, with me writhing in the back seat, stopping and pulling over in snowbanks to pee. And we got back here, and I ended up back in the emergency room again. And that's exactly when I had a doctor say, you will forever be a burden on your family. Right? Okay. But that got my urologist's attention. It's like, wait, you were at the ER 2 days in a row? Yeah, I was dying. He's like, okay, you mean the pain's really bad now? And I'm like, yes, the pain is really bad now. Like, I'm having very dark thoughts right now. And he said, I think we probably need to give you some pain medicine. And so he prescribed me Vicodin, which is a 500 opiate acetaminophen product. Norco is a 325 opiate acetaminophen product. Now, the first time I took a Vicodin, I took the whole pill. And I will tell you, I was dizzy and nauseous afterwards. And some people would interpret that as an allergy. That wasn't an allergy. That was just too much. So then the next time, I cut it in half. And because there are some medications you can cut in half, and there are some that you cannot. And you have to ask the pharmacist if you can cut this medication in half. So Vicodin and Norco have a score down the middle of the pill, which very clearly shows it can't be cut in half. But again, something like OxyContin cannot be. If there's no score, then you do not do that. Do not do that, because you could overdose. So you always ask your pharmacist and or your doctor if you can do what I did. So I went to a half of Vicodin. And you know what? Turn the pain off, and guess what? I wasn't nauseous. I was a tiny bit dizzy, but there's no nausea at all. And I thought, well, isn't this interesting? So the next time I did it, I don't know, a couple days later, I did a quarter. And you know what? A quarter of a Vicodin turned off all the pain, and I had no dizziness or nausea. Now, one of the mistakes that some patients make is they go, "Ooh, I'm in a really bad flare right now. There's more pain. I better take 2." And so they take 2 pills. And if you keep doing that, you start using a lot of pain meds. And then, more importantly, you start looking like you're a drug seeker. And it's not that you're not in pain, it's that you're not understanding how the medication works. Because if a quarter of a pill will turn all the pain off, there's no reason to take 1 pill, much less 2. It's about finding the dose that your body responds to. That's the critical point, is finding the point that your body responds to. And the other thing about pain is it's like fighting a fire. Man, you catch that sucker when it's small and early. You don't wait until you're bawling your eyes out to treat pain. Like literally, my rule is if I'm in pain for a half an hour, I stop what I'm doing, I get my heating pad, and I go sit in the recliner. And I throw the heating pad right on my pelvis because I'm very prone to pelvic floor flares. And if 30 minutes later that pain is still there, then if it's, you come to know severe pain versus mild pain. And I don't even know if I can describe it. Severe pain stops you in your tracks, like moving your body hurts. And it's agonizing and it's relentless. Whereas kind of milder pain, you can get up and do what you need to do. Yeah, you're hurting, but it's not terrible. And so back in the day, now I haven't had this pain I see pain in years. If I get pain, it's a little mild pain. It's not severe pain. But back in the day, I used to have that severe pain every day. And so, or every other day, or several times a week at least. So a half an hour with the heating pad. If that didn't work, I gave myself permission to take a quarter of an Orco or a Vicodin. And you know what? 9.9 times out of 10, that's all I needed. Didn't even have to take more pain meds. I fought that fire before it got out of control. I nipped that in the bud. I calmed those nerves down in the bud. And I stopped that flare from getting worse. Whereas if you wait until your pain is out of control and you're bawling your eyes out, it's going to take a lot more pain medicine to turn it off. And you've kind of sabotaged yourself. You got to nip this sucker in the bud. And there's a lot of decision making that goes on too, because it's like, and this is interesting because I just had a big long discussion with my sister about this. If something hurts me, I have no interest in suffering. It is very easy for me to say, okay, I don't need to do that anymore. It's fine. If chocolate triggers IBS, as it does for me, it's like, okay, I don't like having IBS. I can lose the chocolate. If coffee triggers an icy flare, it's like, okay, I'm really not interested. I'm really, really, really not interested in triggering more irritation and inflammation. So again, it's really easy for me to give stuff up. In contrast, other people are like, well, I'm not going to let IC rob me of something I love. By golly, I'm going to have that coffee every day, even if it causes more pain. And the problem is that you're just throwing yourself into a long-term chronic pain cycle because the bladder can't recover from that. This is injury. For many patients, this is injury. It could be chemical injury. Like if your symptoms started during chemotherapy, well, there you go. You've got a chemical injury of the bladder. You're going to keep pouring acid on the wound. It's going to keep hurting. Your fault. Okay, hold on a second. Susan says, the only thing that calms my flare-ups down, and Dr. Evans suggested this to me, is a Xanax and gabapentin together. It works for me. I've had to fight my primary care to give me the Xanax. You're not the only one. I've heard that from other patients too, Kathy. I've never used Xanax. I've only used Xanax once, and that was before an MRI, so I don't have any personal experience with Xanax. Kathy said, I stayed 4 years without pain care. My relief has come from pea leaf and lactoferrin. Yes. Now the pain is gone to where I'm in pain. Okay, hold on. Okay, I don't understand what you just wrote there. Now the pain has gone to where I'm in pain now when you sit. Okay, so pain with sitting, generally not the bladder. Pain with sitting is usually the pelvic floor and or pudendal neuralgia maybe. Dolphin said, my neurologist prescribed nortriptyline and it helped with my bladder at night. But after this last surgery, my feet started swelling and my feet felt heavy. I got off the nortriptyline and no more swelling. I'm getting up a couple of times a night to empty my bladder. I take Lyrica daily, Lyrica only. So you could try the Peora, which also calms nerves down. That would be a very interesting experiment. Mary said, I stopped taking portions of pain meds like you said. I was taking portions of pain meds like you said. They stopped giving me 48 per month when my urologist retired. I've spoken to the doctors. It's all for nothing. I'm forced to work out how much of a marijuana tablet I can take without getting nausea and to help the pain. Yeah, we're in a era of misinformation, and that includes misinformation with pain care. You know, that I mean, the foundation for all of this is really profit. So back when in the early 90s, right, which is when I was diagnosed, something like Vicodin was, I'm not going to say commonly prescribed, but it was widely available and used. And the pharmaceutical companies saw, oh, well, isn't this interesting? This is a good way to make money. So they started making synthetic opioids. And then they also started telling doctors that they were not addictive at all. And then they started producing massive quantities of these synthetic opioids. OxyContin is a perfect example. And the way it works is you got the manufacturer, and then you got the middleman, and then you got the pharmacy. So it's the manufacturer and the middleman those are the ones that were driving all of this. They are solely responsible for the opioid crisis and where we are today, because they saw that they could sell a lot of it, especially if it was accompanied by language that told doctors these are totally safe and non-addictive, these synthetic opioids. And then they started making pain the next vital sign. And I mean, I watched it all. I was fascinated by it. Again, I chaired our state pain conference, so it all made sense to me. What I didn't understand were the massive quantities of pills that were being sent to tiny little communities. So imagine you've got a pharmacy in West Virginia in a town of 750 people, and they get 50,000 pills. Well, of course, what's going to happen to those pills? Well, they're going to end up on the street. And then doctors started setting up, pseudo doctors started setting up pain clinics, because again, it was all a money grab. Well, so now we've got millions, if not billions, of pain meds circulating on the street. And guess what? Hundreds of thousands of people overdosed and died because synthetic opiates are actually very dangerous. Very, very dangerous. And so we had the opiate crisis, right? And y'all remember that 10, 15 years ago? Teenagers were dropping like flies. They were buying it at school, they were buying it at dealers, and there were people who had children in the back seat of the car. They'd take it, they'd die in the front seat, or they'd be out in a coma. And it became this huge public health crisis. Terrible public health crisis, because legitimately thousands of people were dying. And you can still see it now in some live cams going through Los Angeles or going through Chicago. You can really clearly see the people who are absolutely strung out on these synthetic opiates. It's all about the money, honey. And so the government had to respond. They had to respond. This was a crisis of epic proportions. Like literally almost an entire generation of children were affected, and there were so many deaths. So a secret panel was commissioned by the Center for Disease Control, if I remember correctly. I don't think it was the FAA, the FDA. I think it was CDC, and I think it was under it was Bush, the last Bush. I think it wasn't Obama. It was Bush before that, I think. And they met in secret to create this new set of pain care guidelines. And 18 months to 2 years later, this new set of guidelines that was released that literally triggered chaos everywhere. Because they basically said, take all of your patients using opiate medications off the medication. It's dangerous. And so doctors who were giving, an IC patient, let's just say a very low dose, maybe 10 pills a month, right? Okay, 15 pills a month. Or God forbid, somebody with chronic regional pain syndrome or something like that. You've got patients who are using opiates very safely. They get it from one provider. It's the same dosage. It's the same amount. There's no sign of abuse. Everybody was kicked off opiates. And these patients either committed suicide or they went to heroin. I mean, little elderly dads and moms looking for a drug dealer for heroin to fight their pain because they got cut off of their legitimate pain med. So the chronic pain experts were just stunned and outraged by these guidelines. And there were no names on the guidelines. They hid them. And the chronic pain experts are like looking at this going, well, what about the chronic pain patient? My God, there's nothing in here to help the millions of people who legitimately have chronic pain. And in fact, these guidelines have massively harmed them. And then the names got released. And that's the tragedy, because there was not a single chronic pain expert on that panel. Rather, there were people who benefit from it, who ran rehab facilities, who directly benefited financially from kicking patients off of these pain meds because it forced them into drug treatment centers. And so then, the blank hit the fan. And what a lot of you don't know is that there are a couple of problems with those guidelines in the first place. Normally, guidelines are released by the medical association, not by a government agency. The doctors were infuriated. So those guidelines were edited like 6 months later to protect the chronic pain patients, but the damage was done. And the problem is doctors today they only know the worst case scenario. They don't look at the edits. And there has been a very steady demand that these guidelines have to be completely revisited. And then in the meantime, we've got massive prosecutions now of the pharmaceutical company that told doctors they were completely safe when in fact the pharmaceutical companies knew that they were highly, highly addictive. Right? So that's what created the foundation for all of this. So that company is long gone. What was the name of that company? And then the big thing was to try to punish the family who owned that company. Here, hold on. What pharmaceutical company was shut down because of opiates? Purdue Pharma. Attorney General James on May 1st of 2026 announced that Purdue Pharma was shut down. Oh, and the Sacklers own Purdue. And I actually worked with Purdue on IC stuff. So they now have a different name. So number one, so the settlement amount was $7.4 billion. And the new company is Noah Pharma, which is designed to fund and support addiction. But here's the deal. The family made billions off of this. Were they ever held accountable? No. Personally accountable for the lies? There's really, really good documentaries on this, and I would really encourage you to watch this. Opiates are not the enemy. Opiates are a vital treatment for patients in severe pain. I'm not afraid of opiates at all. It's about knowing how to use them correctly. What is a sign of an addict? An addict is somebody who takes pain meds to escape life and escape their responsibilities. Somebody who's using pain meds appropriately is taking pain meds to function, to do the thing they need to do in their life. So I have no regrets at all. I am not embarrassed by the fact that I needed opiate medications because I knew how to use them. So we are in a pickle right now because so many doctors are afraid. And then the other thing too is that there were some bad actor doctors who legit did terrible things and made a lot of money creating fake pain clinics and just writing prescription after prescription. They deserve to be prosecuted. But then there are other doctors like Dr. Forrest Tennant here in California, who was an incredibly dynamic pain specialist who really was trying to finesse it. And yet many doctors live in fear of the DEA and or the state narcotics group. And so they just don't want to prescribe them because they don't ever want to be investigated. I almost had an affair with a Bureau of Narcotics Enforcement agent. It's funny. He was very handsome. And I took him out to dinner before our big conference, and the invitation was very clear. And I thought, I could jump on him. And then I thought, yeah, I got to chair a conference tomorrow. I better not. Oh my God, I can't believe I just told you guys that. I'm sorry, men in uniform appealing. The other really interesting thing is the actual head of the Bureau of Narcotics Enforcement that I actually talked with was actually a pain patient, So Dolphin said, I take Lyrica only. She says her mother overdosed from opiates. Yeah. She was also prescribed benzos. She lived in a rural community. I reported her 2 providers to the medical board. That was in 2012. There was no punishment. And Dolphin said, look at what happened to the mother who killed her 3 children. She was on 13 antidepressants. Yeah, that's a whole nother story. I mean, Sue just said something funny here. I'm not laughing at this poor woman who she had suffered postpartum psychosis. And it's been a very, very big trial here in the United States because they are prosecuting her for the murder of her 3 children. She had been inpatient in a psych unit. She went to doctor after doctor after doctor. She was on a ton of medication to try to help her because she was so, her brain had been so profoundly changed by the birth of her last child. And that happens. That's well known to happen. But for her, it was incredibly severe. And they had her inpatient and then inexplicably discharged her. And sadly, she heard voices to take her children's life, and she did. And then she tried to commit suicide, and now she's paralyzed. Dolphin said, my mother had neck and back surgery. She took 6 Percocet and 3 different benzos a day. So her pain care, I mean, this is why we need more research. And this is why PEA is so exciting, because palmitoyl ethanolamide has been studied in many different research studies for many different types of pain. It's not addictive. There are virtually no side effects in most of those studies. And it has a significant and measurable effect in reducing pain. We need more research doing that, studying that stuff. You know, if she had had access to PEA, it might have been a bit different. And that's why I'm so vocal about PEA, because I have suffered. Many of you have suffered. And suffering is horrific. I don't want to suffer. I don't want you to suffer. And if there is a chance that if you've been denied over traditional therapy, traditional pain care, what are you going to turn to? Well, we don't really want you to turn to heroin, please. No. We happen to have a supplement called palmitoyl ethanolamide, also known as Pure or P-Leave, with dozens of research studies showing it's effective at chronic pain, surgical pain, acute pain, shingles, fibro, interstitial cystitis, prostatitis, pelvic pain, menstrual cramps. And you can read all that research for yourself right on the front page of the IC Network. I got a big blog that points to all the research. You look at that research. I'm excited about PEA. That is the future, in my opinion, is PEA and lactoferrin and some of the bladder stuff. But this is another reason why we're kind of walking away from treatments that might calm the symptoms, but don't fix anything. We want to fix stuff, right? If we fix it, then you won't have the symptom in the first place. And that's why I'm not a fan of aloe anymore, aside from the fact that there's no research showing that helps, published in a legitimate study. Mary says, I'm aware of how much less I am wanting to get done in my life, getting done because of pain or the effects of marijuana. I've been able to go grocery shopping for 2 weeks now, as one example. Mary, I'm so sorry. So are you trying the PEA, Mary? I don't remember. Anne said, what supplement can I take for the alpha nerve? The alpha afferent nerve in the bladder. Well, PEA can calm nerves down. So I would be trying Peora or P-Leaf. Peora is right in the IC Network shop. It's right on the front page of the IC Network store. It's like literally the one now that almost everybody is trying. Mary says, what I mean is I can't do normal activities. I hear you, girl. I hear you. Been there myself. I have been there myself. And you've been on lactoferrin and the PEA. Okay. And so do you feel like you're getting worse, or are you the same, or are you getting a little bit better? I'm concerned that you haven't been able to go shopping for 2 weeks. Is it because of the pain, or is it because of the marijuana making you a little bit funky? I want to see if I can What? Appalachia. Oh, Frontline. It was Frontline. Did such a great job on the opiate crisis. And I think Netflix did one too. Yeah, Netflix did one too. Netflix has a series, The Pharmacist, who turns to private investigation after his son's tragic death to expose the corruption of pill mill doctors fueling the opioid addiction. And then there's another one on Netflix called Painkiller. But the Frontline documentary is where you want to start. And let me just give you the link to it. I mean, I think every teenager should watch it. I think if you've got anybody over the age of 15. So let me give you that link to that. I think this is the link to that. It just kind of baffles me. Here, hold on. The kids who, is that link going to work? Hold on. Okay, that might have worked. You can just, yeah, that worked. I always say, I mean, guys, listen, I have a degree in pharmacology. Okay, you got to understand, I did surgery for a year. This is a really rare degree, a degree in how to make medication. And I wouldn't trust some of these companies as far as I could tell them. And what they said after I graduated, you can never work as a salesperson for a pharmaceutical company. I'm like, why? He goes, because you know too much. You just know too much now. You're not going to be able to put a positive spin on anything because you understand the concept of adverse events. Peggy said, hello, Jill. Lactoferrin worked for me. Thank you. I would have never known about the lactoferrin if it wasn't for you. Thank you so much. It took about 2 to 3 months to notice any changes, and they just continue to improve. Yay! Yay! Love it, love it, love it. We now have 2 different lactoferrins. We have the original lactoferrin from Australia, which I consider the premium lactoferrin. And then we have a more affordable lactoferrin from the United States. Kathy said, I believe that I have pudendal neuralgia. What can I do for this? So Kathy, if you have pain when you sit down that gets better when you stand up, or if you have a history of sciatica, or if you have PGAD, persistent genital arousal disorder, where you randomly feel aroused and it makes no sense, or you're struggling with pins and needles or areas of numbness, those are all signs of pudendal neuralgia. And so what that generally means is that a nerve is being compressed in some way, usually by a muscle. So the therapy for that is twofold. We want to get the muscles to relax and release, and we want to calm the nerves down. It's pointless to just calm the nerves down until we figure out why the nerve is compromised in the first place. So there's 2 things that have to happen simultaneously. We got to work on the muscles and we got to work on the nerves. And again, the PEA makes great sense for helping to calm those nerves down. Kathy said she fell on her butt a couple of years ago. Yeah, definitely. That'll do it. I have too. Sarah said, I'm in San Diego and Lowell Parsons was my doctor's years ago, so I'm without proper care. When I was diagnosed in 2004, I was an expert for years and went into remission. Now I have no idea what we do now know that it's back. I know it's muscle spasms involved. Okay, so Sarah, there are a lot of physical therapists in San Diego. You can self-refer in the state of California. So as long as you're willing to pay for it, you want to go to a website, pelvicrehab.com. It's short for rehabilitation. pelvicrehab.com. You put in your area code, or I'm sorry, your zip code, and you can find a physical therapist trained in pelvic floor work. And so, Dr. Parsons was part of the old school that believed that IC was an incurable bladder disease, specifically a problem with the bladder wall, which is why he was so heavily involved with Elmeron. But we now know that many IC patients have muscle issues. 87% of patients have muscle issues. We phenotype now. So we're long past those days of assuming everybody has a bladder disease. We know that that's just not true. And so we phenotype now. And the single most important diagnostic test is actually the pelvic floor assessment. So I think you need to go get your pelvic floor assessed, because he really wasn't, well, I don't want to say anything else about him because I wasn't his patient, but I will just say that approach to IC has been replaced by a new approach to IC, specifically pelvic rehab. So go there. And if you want to, I'd love to chat with you. I mean, I was the support group leader here in California for many, many, many years before I stopped that, and I do the national support groups now, but I'm always happy to talk with patients, always. All right, guys. Well, we've been going for almost 2.5 hours. I had root canals on both of my front teeth. These are crowns. And I had to have one of the root canals redone, and I think I have to get the other one redone because it zings me every now and then. It just zinged me. It's not terrible, but it's annoying. That was from TMJ. When I was a kid, our dentist hollowed out all of our teeth and put mercury fillings in them. So like all of my molars, those are all root canaled and crowned everywhere. All of them. Except for like 2. Because they all cracked and broke from all the mercury. So it sucks. But hey, at least I have teeth. And we're now at teeth maintenance mode. Let's just try to hang on to teeth as long as we can. My dad at the end, again, he was 100 and a half. I think he had 4 teeth left. And he hadn't gone with COVID, hadn't gone to the dentist in like 3 years. And he was not very good at brushing his teeth. I kept helping him with that. And so he needed a root canal, and they tried to do it, and he just couldn't tolerate it. They had to pull it out. It was hard. So no, I don't eat any hard, try not to eat anything hard candy or anything like that. And I don't eat candy at all, because I'm trying to save the $40,000 I've invested in my mouth in the last 10 years. It's ridiculous. Knock on wood, knock on wood. Nothing else happens. Life, right? Can you take, okay, hold on. Christina said, I have violent bladder spasms and vaginal spasms 24/7 that causes pain and urgency. I feel like a baby is kicking inside. Muscle relaxers for the bladder do not help. What helps with the spasm? So Christina, what you're missing is that there's 2 different types of muscle. The bladder is made of smooth muscle. The pelvic floor is made of skeletal muscle. They require different medications. So if we want to try to calm the smooth muscle of the bladder, it's going to be something like oxybutynin, also known as ditropan, or right now mirabegron. But if we're trying to relax the pelvic floor spasms, it has to be a skeletal muscle relaxant like baclofen, Baclofen, or Flexeril, or like a vaginal Valium suppository. So of course the bladder antispasmodics are not going to help a pelvic floor flare because they don't target pelvic floor muscles. So you need a skeletal muscle relaxant, baclofen, Flexeril, Valium. Veronica said, I got liposomal PEA on Amazon in Scotland. This seems to be similar to the one you have. Great. Great. Sarah said his approach didn't help. The constant installations are exactly. And now we have our first patient who had Elmeron by bladder installations who now has eye damage and bowel issues. So, yikes. Irene said, can you take PEA if you're on gabapentin? Yeah. And you might end up taking less gabapentin. There's a lot of discussion about that in the journals. Cynthia said, what's a website for pelvic floor? pelvicrehab.com, short for rehabilitation, pelvicrehab.com. You're welcome, Kathy. Thank you, Veronica. Brandon said, are there any recommendations for aftercare for pain after ejaculation in men? Brandon, great question. I would think a rectal Valium suppository. Hold on. It is in here. So 6 years ago during the AUA conference, there was an excellent class on IC, and the instructors specifically mentioned a rectal suppository by Fairwinds Cannabis called Rectify, Rectify. So if you want to go the cannabis route, that's not me. I have no experience with this. That was taught at the Chronic Pelvic Pain course in 2018 at the American Urology Association. And it was actually Dr. Robert Moldwin's wife who brought it up. Jennifer Fariello Moldwin shared that they are seeing great success using medical marijuana suppositories, specifically mentioning Fairwinds Cannabis infused vaginal suppositories that they called Feminine Relief, and rectal suppositories called Rectify. And that is in our summer 2018 IC Optimist magazine. So if you want to get our magazine, become a member. And that's what supports these meetings, me doing these meetings. Christina said, you tried Flexeril, baclofen, and mirabegron, none work. Okay, so number one, you can't compare them. They're not the same. Mirabegron is designed to calm nerves in the bladder. It's for overactive bladder. Flexeril and baclofen are indeed skeletal muscle relaxants. So it would be, I guess what I would ask you, Christina, is what do you think makes it better? Like, does a heating pad make it better? Or does ice make it better? Like, what do you turn to when you're in pain? Because if heat makes it better, then we're working on muscles. If ice makes it better, then we're probably working more on nerves. So again, I would be throwing PEA into the mix, Peora. Here, where are the bottles? Peora, P-Leaf. If you go to the front page of the IC Network, you will find it's down at the bottom under products that can help. You can look at all the research. And you can read that research for yourself to decide if you think this is promising. I think it's quite promising. And I will tell you, when the ICPEA study was presented, the doctors were ecstatic that we had something that now has a proven track record of reducing bladder pain and pelvic pain. And there are now 3 different studies on IC, chronic prostatitis, and pelvic pain. That is not an opiate, that is not associated with addiction in any way. Brandon said, I failed a lot of skeletal muscle relaxers, and I personally find Soma the most effective for me. I have severe myofascial pain. Thank you for that suggestion. That's great. And Mary says she uses a heating pad all day. Now, I will tell you, I sleep with a microwavable heating pad. I am muscle and nerve driven too. And I have our big, let me go get it. Here, hold on. Man, these incisions just annoy the heck out of me. Okay, so we have heating pads that are custom made for us on the IC Network website. Look at this. Perfect shape. This is the perfect shape for pelvic pain. And it's a chunky, it is a chunky heating pad. So it's going to hold whenever I get up to go to the bathroom, which is usually once a night. I usually sleep for 4 hours, and then I wake up, put it in the microwave for 2 minutes while I'm going to the bathroom, and then I just bring it back. I bring it back to bed with me, and sometimes I tuck it under my pajama bottoms and really get a lot of strong heat on my pelvic floor. My pelvic floor stays persistently tight on the left side because I have SI dysfunction. I have scoliosis. So my left pelvic floor is always on the tight side. So if you want a heating pad like this, they're over on the IC Network. And I love them. And I have a bunch of them myself, and I use them every single day. The only thing I would just say to you is you can microwave it, but remember, microwaves work based upon moisture content. And I had one of these that I used for like 5 years. And then one day I blew my microwave up. It just shorted out when I was microwaving a heating pad. And I called the company. And it was a new microwave too. It was like it only had it for like 6 months. And the guy came out, and I showed him, it was like this, and he goes, you do realize that no microwave is going to be able to handle that over time, because there's no moisture in it anyway. There's hard rice in this. And so he said, you need to microwave it there's got to be water in the microwave. So I have a little measuring cup of water. And so I'm preserving my microwave with using this at the same time. This is my best friend. I love my heating pad. Boomer, hey, this is the guy who was in a sub with like my brother. You got the lactoferrin, and seems to be working. Yeah, baby, another nuke, huh? Are you another subber? What's the right word for a submarine guy? I forget. Anyway, excellent. I'm so glad that it's helping you. Proud Navy family here. Proud Navy family here. I mean, we go back before to World War I in the Navy in my family. Christina said, "Does acupuncture help with bladder and pelvic spasms?" I don't know. I honestly don't know. Let me see if I can find it. Okay, hold on. Calm bladder spasms. Okay, the National Institutes of Health says yes. Acupuncture can help calm bladder spasms and reduce overactive bladder symptoms. It works through the traditional concepts and modern nerve stimulation. Though medical research says it can vary from person to person. So doing the ankle stimulation, that's one way. Ow, sorry, that's my incision. Ow, stop it. Ow. I got this one spot on this side. Stop it. Breast cancer incision. Okay. So the answer is yes, it could. Probably worth a try. You're squid, subqualified until I die. Absolutely. You know, so hey, Boomer, can I hold on a sec? Because I got to ask you a question. Hold on. Okay, I need your opinion. So my dad was not a boomer. Okay, my dad did aviation ordnance. Right? So this was on all of his jackets or sewer pipe sailor. We have this symbol. We're very proud of what he did in World War II. He was stationed in San Diego, loaded bombs on planes, and specialized in ordnance. I don't know what to do with his jackets that have this. I don't feel like it's right to give them to Goodwill because I don't think just anybody should wear them. You know what I mean? It's kind of like stolen valor in a way. So, what would you do? What would you do with something like this? Am I being too picky? Do you think I should donate it and let somebody wear it who might not understand what this means? You know, I love my dad. I want to honor him the right way. Oh, you donated to the VFW? Well, why did I never think of that? I can do that. Oh my God. How could I have forgotten that? Thank you. Thank you. I can definitely do that. And I've got, it's only stolen valor if it's included as a military patch. Okay. Okay. You know, I even have, hold on. Oh, I can't find it. But I have the original hat that he wore with VFW with all the patches on it. What we called a crow, which designates the rank as an enlisted. Yeah, he was just enlisted. His dad was the officer in what was he? Was he a commander? Or one step above a commander, maybe? Running radios in the Philippines and then in Seattle. He was in Cavite and then he was in Seattle and a couple of other places. They didn't see him for a couple of years during the war, for sure. The big war. But now we're all big war. Oh my God, let's just not even go there. Ugh. Okay. All right, so hold on a sec. What have I missed here? Brandon said, okay, hold on. Sue says, I think I now know why my mother's microwave died during her rice bag I heated for her during her cancer treatment. Exactly. I felt, the technician rolled his eyes at me and said, you should have known better. And I'm like, don't you even know how a microwave works? I'm like, well, I microwaved it for years. It's like, yeah, but it needs water. And you've taken all the water out of it. Yeah. Okay. So there you go, Sue. Veronica says, thank you again, Jill. Have a lovely evening. I'm off to my bed now. Hopefully we'll get an hour or two sleep before I'm back up. Sleep well, honey. Sleep well. I wish you the best. I am. It's just a journey. Sarah said, it made me relax and exhale, which helped me release the constant tension. It helps with my migraines and when I have back spasms. So I'm hoping that it helps the pelvic floor spasms too. I've been told by pelvic PT I have constant spasms, super tight, also extreme weakness in the pelvic floor, both at the same time. That's normal, honey, Sarah. That's exactly how I was at first, for sure. And I remember the very first pelvic floor assessment I had. That's exactly what they found. And the way she explained it is when you injure muscles like through falls, they do get progressively weaker, but they still have a job to do. So what happens is they get tighter and tighter and tighter. And so therapeutically, it's a two-step process. You have to release the tension first, and then you have to strengthen the weakened muscles. Sarah said, can I get them made into a quilt? No, I only have the one jacket left. It's hanging in what was his closet that is now my closet. I just have a couple of things of his that I just can't let go, and that's one of them. Robbie said, does my brother have children? No, he doesn't. He doesn't. My brother is a nerd's nerd. He's a nuclear physicist. Very, we're talking the guys who got the perfect scores on all the tests. So they're very academically wired, not socially wired. Not socially wired at all. Sue says people spend a lot of money for those jackets at garage sales because they're vintage. I also have an old leather aviator jacket, but I think we gave that to my nephew. One of the original naval, because my grandfather on my mother's side was the first man to solo off the very first aircraft carrier in the U.S. Navy. His name was Leon Swede Larson. They called him Swede. And I've got pictures of him too. So both of my grandfathers were pilots. And Grandpa Leon was a test pilot for the Navy. He actually flew the fighters they captured. So we have a picture of him flying a German fighter to try to understand how the planes worked and what the advantages were. And then he flew around the Secretary of the Navy for a year or so during World War II. He was also the first test pilot for Beechcraft. And boy, did he have stories about Walter Beach. And he was he was an excellent pilot. In fact, my mom flew when she was 6 weeks old. She had her first plane flight with her dad. Walter Beechcraft, Walter Beach, who started Beechcraft, they were flying and across the country for something, and he wanted the controls of the plane, and Grandpa said, "No, you've been drinking." Walter Beach was not happy about that, but my grandfather refused to give the controls to somebody who'd been drinking. And then he refused to fly through a storm, and they gave it to a younger pilot who died in the storm. And he actually trained Amelia Earhart in something, and he met the German spy, the woman who was flying around. I think she was saying that she was a Canadian pilot flying around to all the air bases, picking on American pilots, trying to get intelligence. And yeah, he even had an encounter with her. Yeah, great stories to share about those World War II flying days. Brandon said, when acquiring supplies to do home bladder installations, what's the best way to buy hypodermic needles in bulk without a pharmacy being well, but why would you need a hypodermic needle for a bladder installation? You would normally need a catheter. So I don't understand why you would need a hypodermic needle. I mean, if you need the casing to put the medication in the catheter without the needle, I mean, that shouldn't raise any alarm bells at all. So help me understand, Brandon. Karen said, no one will appreciate like you can. Keep it for yourself. Bless your dad. Yeah. I feel him all the time. I think he's proud of me. I think it was very hard for him to admit he needed help. 100 years old and he wanted to drive. That's one reason why I have blood pressure today. I got blood pressure caring for him that last year. Yeah, to draw it from the bottle into the cath tip. So that's what I thought. I get it. Yeah, thank you. Sue said, yeah. Susan, do you have a suggestion for him? Does anybody have a suggestion for him? I just don't know. Nobody's ever asked me that question before. Sarah says she does home instills, and the needles to draw up the meds come with the medication. Sarah, are you allowed to okay, so you're not, so number one, you're not injecting it into, the needle is not coming in contact with any part of the body, right? That literally, it's a sterile needle. You take off the cover, you stick it in the meds, you pull it up, you put the med into the catheter, then you put the needle cover back on. Are you allowed to reuse those? Because they're, I don't know. You have to use a new sterile one every time you do it? I'm probably showing tremendous naivety there. Mary says, no, you do not reuse it. Okay. When I got my degrees, I was taught. Sarah says she does not reuse. Okay. Excellent. Susan said, my husband had to drop sodium bicarbonate, lidocaine, and heparin out of the bottle into one syringe. Okay, I get it. Okay, that makes sense. When I got my degree, oh, Sarah says low friction catheters are key, so much less pain. Exactly. Low friction catheters are the bomb. They're so important because they're slippery. They're easy to slide in and they're easy to take out. You never use the red rubber catheters. Never. Those are a nightmare. And Susan says to not use or reuse the needle. I'm trying to remember what we did in pharmacology, in our pharmacology, but God, it was a long time ago and I don't remember. All I remember was we had incredible sterility and safety protocol that I remember implicitly how to do. So, I mean, I could make probably a very flawed argument, but it's not like we have, I'll have a fume hood. Normally you have a fume hood where you're not breathing on it and breathing bacteria on it. Mary says she uses a vinyl catheter. Okay. Thank you. You guys reinforced an important concept for me. Thank you very, very much. Simon said, yes, you don't want anyone wearing those. Smart thinking. Boomer says, you found that insulin is a major contributor to my issues, trying to get my sugar under control now. Dude, let me tell you, we're learning so much about the effects of sugar. Like, I didn't realize sugar fed cancer. I don't eat any sugar now. None. Oh, and there's this new sugar called allulose. Like, yikes. No. Simon said, that's awesome. Wonderful stories. You should be proud. Simon, we had this huge display of Grandpa Leon's exploits in the San Diego Air Museum, and it burned down. So we lost 95% of it because the whole museum burned. But I still have pictures and stuff like that. This was back in the day when if it were dark and there were no lights at the airport, you'd buzz a little community airport, and then people would come out in their cars and use their headlights to light up the runway. They legitimately did that back then, and we have stories in the newspaper about my grandfather, my mom's dad, and landing the family in airports like that. And my mother trained to be a pilot, and she did all the training, and he refused to let her solo because the war had just ended, and he just said, I don't want you taking a job away from a pilot who's coming back from the war. And I will tell you that haunted her the rest of her life, and that you could not have made her happier than just driving out to the airport, sitting in the car and watching the planes. There was a very interesting story, by the way. And I don't, when grandpa passed away, they knew he was very close to death. He was in Colorado. She was here. All the sisters got together and they were all flying to Colorado. And he actually died while they were on the plane. Well, my mom didn't know that. Obviously, they didn't have cell phones or anything like that. She loved her dad very much. He's a little guy too, chronic smoker. He's a funny little guy. She looked out the window, and she saw a biplane that wiggled its wings at her, and the pilot waved, and then the biplane went away. And she was on a jetliner. She absolutely insists that that was her dad coming to her saying that he was fine. And she went to her grave saying that happened. Melissa says, Mayo Clinic refused me. The only help they would give is through pain clinic. When I tried to go to other urogyns, they refused me because I was going to their pain clinic. This was in Jacksonville. I was told they won't see anybody with IC because they know there's no cure. They don't want the headache. I spoke with the head of gynecology. So Melissa, this is exactly what we were talking about at the beginning of this meeting. I will tell you very honestly, Mayo Clinic has a horrific reputation when it comes to IC, especially Mayo Clinic in Minneapolis and Mayo Clinic in Florida. Even Mayo Clinic in Arizona for many, many years, we never sent patients to Mayo Clinic. The patients who went to Mayo Clinic I can give you a true story. I will give you an absolutely true story. Mayo Clinic story. So I had a gentleman call me who had just hired a plane to fly his wife back home from Mayo Clinic, Minneapolis, because she was treated so badly. So this was obviously a very wealthy man. And he had prostate cancer. When he got prostate cancer, he went to Mayo Clinic and he got treated for it. And so several years later, his wife gets IC. He's like, I'm going to take her to the best place I can take her, Mayo Clinic. So they flew on a private plane to Mayo Clinic. And he was appalled at how she was treated. All in your head kind of moment. And he packed her up and they flew right back to, I think they were in North Carolina or South Carolina, somewhere on the East Coast. And he called me. And he was so angry at how she was treated as compared to how he was treated. And he's like, I want to fix this. He had a ton of money and he's like, what can I do? What can I do? This was absolutely unacceptable. And, whenever I've had more wealthy people contact me, I usually I always point them to an IC research center that is doing good work, like Ken Peters Clinic or Wake Forest. And so that's what I did. I didn't ask for it. I would never ask for any of that money for myself, as much as I'd love to have it. But he was just so horrified by how his wife was treated. And I can think of several patients that I've worked with who have had very, very similar experiences of basically being disregarded, told it was all in their head and all that sort of stuff. So we stopped referring to Mayo Clinic probably 25 years ago. Probably 25 years ago. So it is what it is. They are stuck in an old school model of IC. And so what I say to patients is just don't say you have IC, just say you have pelvic pain. And you don't know why you have pelvic pain. Is it endometriosis? Is it this? Is it that? You're going there for help with pelvic pain. Once you sell pelvic pain, you get in the door. As soon as you say interstitial cystitis, that door is shut. So I would do that. Mary, no. All right. Simon said, oh, no, so sorry. Pictures are good. Yeah, no, I still have pictures. I got boxes of pictures that my mom saved. So I can share them. Definitely. In fact, I think I even have, here, hold on. Okay. So he flew with Charles Lindbergh, right? So Charles Lindbergh flew the Spirit of St. Louis. He flew, and I don't know if you can see this here. You know what that is? That's a Spirit of Progress. That's now in an aviation museum in Japan. And you can just see the PRO. Same plane, same manufacturer. They flew together. I got lots of pictures like that. Yep. All right, guys. Well, listen, we've been going for 3 hours here. And you know what? Tonight is the last night of the county fair. And I'm going to run down to the county fair and do a quick walkthrough. So I'm going to call it right here. I will see you guys next week. Knock on wood. Knock on wood. In the meantime, if you found these meetings helpful, please think about becoming a member of the IC network, because that's what helps to pay for all of this, because it's expensive. Paying for all the internet and the streaming and the websites and the writing and the research and all that sort of stuff. So what am I doing this week? I am working on, so that the IC Optimist is done. We are working on our pink guide, and we're working on our brand new store. We will have a brand new store launch probably by the end of the month, much better than the one we have right now. So, all right, I'm going to call it. I'll see you guys later. I truly hope you sleep well tonight and you have a good week. And as always, if anybody needs help, feel free to give the IC Network a call. You can find our number right at the top of our website. It's 800-928-7496. I work on a first come, first served basis every day. If I don't answer the phone, feel free to call back. Feel free to be the squeaky wheel. No, it's very common for me to return phone calls later in the afternoon and sometimes in the evening. All right. So I will see you guys later. And to everybody who's doing well on the lactoferrin, yay, I'm so glad. That's wonderful. All right. I'm going to say goodbye to Facebook. And I'm going to say goodbye to YouTube. I'll see you guys later. Thanks for hanging out. And thanks for listening to the very end.